Welcome to COVID's Lasting Impact, Caring for Immigrant, Migrant, and Asylee Patients, a 10-episode mini-series within Migrant Clinician Network's On the Move podcast, a podcast dedicated to providers who work with vulnerable populations, specifically migrant populations. In this mini-series, MCN provides clinical teams, including community healthcare workers and primary care clinicians, with up-to-date information, expert guidance, resources, and relatable case stories for identifying, treating, and managing COVID and long COVID among U.S.-based immigrant, migrant, asylee, and limited English proficient patients in the outpatient setting. MCN is a national nonprofit with extensive experience providing timely, practical solutions at the intersection of vulnerability, migration, and health. Each episode provides clinicians with impactful tools and information for improving the quality of COVID care for vulnerable populations. If you want to hear future conversations on the topic of health justice, be sure to subscribe to the On the Move podcast. For resources mentioned in today's podcast, be sure to click on the link in our episode notes to go to our podcast page at migrantclinician.org/podcasts.
Welcome, everyone, to today's podcast. And the title of today's podcast is The Psychosocial Impact of COVID on Patients and Family Dynamics. And I'm Dr. Ed Zurawesti. I'm the founding medical director of the Migrant Clinicians Network. And I'm happy to begin our first episode of MCN's podcast mini-series, which we've titled COVID's Lasting Impact, Caring for Immigrant, Migrant, and Asylee Patients. And I am delighted that our first speaker is Dr. Kata Weingarten, who's with me today. And we're going to talk about the psychosocial impact of COVID on patients and families and how clinicians can help vulnerable communities suffering from these impacts. So Dr. Weingarten is the director of the Witness to Witness program for MCN, and we've shortened that to W2W. And the goal of W2W is to help the helpers, primarily serving healthcare workers, attorneys, and journalists who are working with vulnerable populations. Kata received her doctorate from Harvard University and is taught at Wellesley College and Harvard Medical School, where she was an associate clinical professor of psychology in the Department of Psychiatry at Children's Hospital in Boston, and then Cambridge Health Alliance, and at the Family Institute of Cambridge. She founded and directed the program in Families, Trauma, and Resilience at the Family Institute of Cambridge. She serves on the editorial board of 5 journals. In 2002, she was awarded the highest honor of the American Family Therapy Academy, the award for distinguished contribution to family therapy and practice. She's written about her work in 6 books, which she had authored or edited, and over 100 articles, chapters, and essays. Her most recent book, Common Shock: Witnessing Violence Every Day, How We Are Harmed and How We Can Heal, won the 2004 Nautilus Award for Social Change. Dr. Weingarten's work focuses on the development and dissemination of a witnessing model, and her work on reasonable hope has been widely cited. And I have to say on a personal note that I am so delighted that we met Kata probably a little over 5 years ago. And for the last 3 years, she has brought Witness to Witness into MCN. And it has been a huge game changer for our organization. Not only externally, where we work with the clinicians that work with the population that we serve, but also internally, it's been a great help to the staff of MCN. So welcome, Kata, to our first podcast.
Thank you, Ed. I'm delighted to be here.
All right. Kata, as I mentioned, has done a great deal of work and actually came into MCN right when COVID was beginning. And so she's done a tremendous amount of work on helping us develop our work with COVID, working with our clinicians, but also working with the population that we serve. And as I mentioned before, a lot of work with the stress and strain that COVID has created to our staff alone. Kate, if you wouldn't mind briefly explaining how your work has related to COVID.
So, I think you're right that in March of 2020, when in so many areas of the country people moved into quarantine or isolation, or some people were using the term lockdown, that was a moment that our programming had to pivot. And what we really tried to do was to help people see that the skills they already had could also pivot to address the emerging needs of the communities they were working with. But one of the things that we also wanted to point out was that when you have a public health disaster or emergency, it means that for clinicians, they are going to be experiencing the same disruptions or similar disruptions to the people they serve. And there is a term for it called shared trauma. So the clinician who may be concerned about the impact of COVID on their family, their extended family, is now serving and helping a patient and a family with the same concerns. And so one of the things that we try to help clinicians with is, first of all, to accept this is inevitable. If we're in a context where everybody is going through the same thing, yes, there are going to be challenges that they're not unique, but they're unusual. And we have to accept that we have to be thoughtful about this. The second thing that we tried to do is to say, under these circumstances, it's even more important than usual to address your own self-care. If you're not taking care of yourself, if you're not attending to the needs of your family, you're not going to be able to show up at work and do your best work. So we really emphasize self-care in a very particular way. We've also introduced the importance of the concept of self-compassion, where we really are trying to build skills for clinicians to recognize that, yeah, the situation's gotten really complicated, and self-blame, perfectionism, those kinds of coping strategies don't really work in that context of complexity. But extending compassion to the self and managing self-care, that actually does help people cope.
I've got some other questions I'd like to really delve in a little bit deeper and do a deeper dive here. So let's start out by saying, can you explain how social and structural factors can affect the health of body and mind?
Sure, and I appreciate your saying body and mind, because at least our perspective in our program is that the body has an impact on our mind, the mind has an impact on our body, that this is an integrated, holistic system. And then we know that our, individuals in different communities have differential access to resources. And our access to resources impacts our individual and family and community resilience. And we need resilience to get through difficult times. So there are structural injustices in our country. We wish there weren't, but there are. And it shows up in differential access to well-paid employment, just even employment itself. Shows up in differential access to adequate housing, healthcare, and they're more stressors for some people than for others. And during COVID, this was all of these, you might say, health inequities, structural injustices were amplified for the communities that, MCN and our constituents primarily serve.
Okay, my next question is, how have you seen COVID and long COVID impact families through changes in functioning of the body and mind?
So, this is a topic I can talk on for a very long time. I think initially, one of the experiences that happened internally to families is that there could be different perspectives on whether COVID existed or not, whether somebody had COVID, or what to do about it if they did. So there was kind of in the situation where COVID was new for all of us in any family, there was often just plain confusion. What is this, and what do I do about it? And there really wasn't absolute clarity coming from sources, public health sources, the CDC, that everybody agreed this is, definitive information. And you may, well, I know you remember, but many of our listeners will remember that even in the beginning, many people, I certainly did, I was wiping down all of my groceries when I brought them into the house. I let my mail rest for 24 hours before I touched it. We had one idea about how COVID spread, and then it changed. And of course, when information changes, sometimes people feel more confident in the new information, and some people feel less confident. They feel like, well, you said this and now you're saying this. I can't believe you. So that also had an impact on how families coped. Then it was often very confusing. Should I go to urgent care? Can this person stay at home? Does this person need to go to the emergency department? How urgent is the situation? And inside families, unfortunately, often this produced conflict. So let's say the wage earner had symptoms that the wife thought were symptoms of COVID. And the wage earner said, no, they're not. And if I don't show up at work, I'm going to get fired. And if I get fired, we're not going to eat. We're going to lose our housing. And the wife was saying, yeah, but if you get really sick and die, you're not going to have a job either. So you can see how conflict took off. And that was just in the context of a possible COVID diagnosis. Then we can kind of fast forward, and we know that some people who did get COVID went on to really suffer longer term. And although there's a great deal of variety in what is now called, long COVID symptoms, it is very often accompanied by lasting fatigue and poor memory, and what is called colloquially brain fog. Well, you can imagine how fatigue, brain fog, and difficulty with memory show up in family life, right? So these are difficult for the individual, but they have impacts on families. So, and that's sort of an overview. I hope that's
It's
giving
very
some
helpful.
suggestion.
Very helpful. And in your program is called Witness to Witness. And I think for our audience, it'd be great if you could just tell us, what is witnessing? What do you mean when you're saying witnessing?
So a witness is somebody who is present for and really taking in and understanding what it is that they're observing in the person that they are the witness to. And when we do that, let's say in the context of family life, let's say I have a partner, or let's say I have a child who's sick with COVID, and I've had a grandchild who's sick with COVID, but so this is, real. and you see the person having a high fever and, vomiting and feeling awful. As a witness to your child, your grandchild, you're really taking in this person is suffering, and it has an impact on you. It's not that you're not a bystander. It's not like, oh, I see it and it doesn't impact me. If you are a witness, you are present, you observe, and it makes a difference to how you feel. In some situations, we can feel effective and competent because we know exactly what to do. But in other situations, we are a witness and it's confusing and we don't know what to do, or we don't have the resources we need to do what we know needs to be done. And in those situations, we don't feel effective and competent. We feel frustrated and we feel helpless. And during the experience of COVID, for many families, they felt they were in that witnessing position where they felt frustrated and helpless. What do I do? And that's certainly the case in families where you have a person with long COVID, where the family member really, just as the medical profession is uncertain what the best treatments are, the family member is uncertain about how best to help their family member with long COVID. Is exercise good? Should they rest when they're tired? Should they push through fatigue? It's all really very confusing. And then you're witnessing it is having an effect on you, but it's just, you feel frustrated because you don't really know what to do.
Those are great aspects, and it really tells how witnessing the suffering of others has a big impact on all the family members. Um, so if we can shift gears a little bit and talk about self-loss. If you can give us a definition of what is self-loss and how can illness create an experience of self-loss for patients?
So I appreciate that question, and I will tell you that when I introduce the concept of self-loss in the webinars or the peer support groups or the various contexts in which our programming exists, we get people very teary and they go, finally, I'm hearing something that helps me, puts words for an experience that I'm having. So people who live with a gap between who they have been and who they are now are living with self-loss, and that gap is painful. So if you have been a very energetic person, enjoyed being out in the world, and now when you exert yourself, you are completely exhausted. Your experience of who you are, what you can do is really different from the idea you have about yourself and actually how you are able to act in the world. And that gap we call self-loss.
Okay, great. That's very helpful. And I think we probably have a lot of clinicians on the line here for this podcast. And so, and when we say clinicians at the Migrant Clinician Network, that's a very broad category. We mean anybody who has any interaction with patients, with the community that they're dealing with. So outreach workers and nurse practitioners and physician assistants, as well as doctors, nurses, and dentists, are all clinicians in our mind. So, Kata, how can clinicians who are aware of psychosocial impacts of COVID and long COVID, how can they help their patients and their families moving forward? So, what advice do you have to those of us who are clinicians out there?
So this may seem like a strange piece of advice, but it is one of the first pieces of advice that I offer clinicians. If they have not had COVID themselves, I strongly suggest that they think about or recall the worst case of flu they've ever had. And they remember what that was like. And that will ground them or help them be present to patients who come in and talk about either an acute case of COVID or long COVID. The second, I think all of us need to kind of do what is called embodied listening, where we allow ourselves to, well, truly witness, to be fully present. And at the same time, we have the humility to know that although we want very much to understand people's experience, we can't do it without hearing from them, right? So we really need to be asking people to help us understand what it is that they're going through. I think, as I mentioned earlier, that building resources of self-compassion are really important. And an easy way, I think, of doing it is to ask yourself, in this situation, if my best friend were feeling this way, what advice would I give them? Because often we know exactly what will be helpful, but we don't do it for ourselves, whereas we're very capable of wanting our best friends to take the best care possible of them. And then I think we have to kind of be able to build up the muscles for tolerating frustration, uncertainty, and of course, grief, because some of our patients will die. Some of our patients will be very sick for a very long time. And we want to be able to be alongside them, be present. And it's hard. It's a muscle. It has to be, built up.
I think it's important that you emphasize listening. I think as clinicians, we're always good at asking questions, but we're not as good as listening to the answers. And we're not as good oftentimes at hearing what we're listening to. So
Yeah.
not only do you listen, but you have to hear what the person's saying and then really internalize that and try to help them. So I think these are all very, very helpful, Kata. And I want to mention that W2W has an abundance of resources on the topic of witnessing and emotional health. W2W has a podcast called We Do Hope, which shares information about various topics to sustain reasonable hope for clinicians serving vulnerable communities. So I would encourage our listeners to listen to those podcasts. And all these resources will be linked on the webpage in the notes section of this episode. I'd like to thank all of you for joining us today to speak with Dr. Weingarten about this. I'd like to thank Kata for this presentation and everything she does every day for not only the population we serve, but the staff at MCN. And any final thoughts before we close?
I think what I would underscore is the point that you made about the importance of hearing when we listen. And I feel very heard by you, Ed. Thank you very much.
So you can reach Kata and W2W through their webpage, as well as emailing them at w2w@migrantclinician.org. I also want to share that MCN is hosting a free webinar on COVID care since the public health emergency ends today. We're going to have this webcast on May 31st, and you can sign up on our website. For some more expert guidance and tools to improve the quality of COVID care for vulnerable populations, you can follow our podcast, On the Move with MCN, and come back and listen to more. So thank you very much for participating, and thank you again, Kata, for all your expertise in sharing with the audience, and hope you'll all come back for our next podcast. Thank you.
To access resources mentioned in today's podcast, click on the link in our notes section to go to our podcast page at migrantclinician.org/podcasts. Visit migrantclinician.org/sign up to join our email list and subscribe to our blog to get updates on new MCN podcasts, resources, and webinars. Migrant Clinicians Network is a national nonprofit dedicated to providing practical solutions at the intersection of vulnerability, migration, and health. We offer technical assistance, health provider capacity building, resource development, research and data and evaluation support, and virtual case management for mobile populations, and free resources and training. The information in this podcast is for trained healthcare professional education only. Information should only be used in combination with up-to-date national and international guidelines. The information is not to be used as healthcare advice for the general public.